Hello and welcome to Health Show with Amara. I'm Dr. Amara Sohail. Another health topic, and today's topic is early pregnancy losses. To be a parent is every couple's dream, but not all couples, they are fortunate enough to have it that easy. 1 or 2 pregnancy losses is common, but 3 or more is extremely uncommon. Only 1% couples, they have 3 or more losses. When that happens, the couples, they get a major impact on their mental health. It affects their relationships, and they feel that their dreams have been shattered. And not always there is a cause for this, because to them, they may think that there is something majorly wrong and that there is no hope. To discuss that, I've invited today one of my consultant colleagues with whom I share a clinic where we look after these couples. We offer them not only a care plan, but also psychological support. Let's welcome Dr. Tamara Everington, who along with her clinical hat is also a chief clinical information officer in her trust, where she has made a significant difference in digitalization of the patient records, as well as she is also involved in so many integrated projects within the region. She is also an associate medical director for change in the Trust's integrated improvement programs. So, Dr. Everington, thank you very much for joining us. So, as you heard, please tell us about the service that you offer to women who suffer from recurrent pregnancy losses. Tell us about your contribution and your services that you offer to such women.
Thanks, Amara, and thanks for inviting me today. I'm really glad to be here because it's a real privilege to work with you in this clinic. I feel very deeply for the couples that are affected in this way. For many of us, we go through life on the assumption that we will be able to have children when we're ready to do so. And for women in particular, they spend a lot of time thinking about preventing having children. So to then find themselves in the situation of not being able to successfully complete a pregnancy, that is an absolutely devastating blow. And it's a devastating blow for the women, and it's a devastating blow for the men as well. And I'm not sure as a society that we're very well equipped to deal with that. It's something that is very much under the covers and not talked about. And that's a pity, because so many people have suffered that it's good for us to share and learn about this together. So in our clinic, it's you and me, and we have a specialist nurse who supports us, and we also have a psychologist who can provide input, because a lot of the people that go through our clinic have been really traumatized. They've got a great deal to deal with from what's happened to them in the past. So I'm a haematologist by background, so that's a blood doctor, and I look after people that have general health problems and also people who've had clotting and bleeding problems.
So, as you mentioned, we do this clinic together, and we see the couples. And tell us your experience when these couples come to our joint clinic. I mean, we know how they present, and on arrival they look scared, because most of them, they think that they will always remain childless, and they are so unlucky, and most of the times women, they take the blame on them. And so you tell us about how common the problem is, and what sort of things that we do offer to them, and what investigations, and how do we manage if we find a problem or if we don't find a problem. So tell us just the overview of the things that we do in the clinic.
Yeah, so most people arrive to us with the assumption that because things haven't gone well for them so far, that that is going to be the case going forward. And so one of the first things we do is reassure them that although having three or more miscarriages is something that only affects 1% of the population, it is nonetheless 1% of the population. So it is quite common. And we can also reassure them that in the majority of cases, healthy couples will go on to have a successful pregnancy, and that much of our role is to exclude any health problem, to provide some support and guidance to help them deal with the trauma that they've suffered and to plan for a future pregnancy, including thinking about their emotional health and how they're going to deal with pregnancy as it arises. So there are some basic health checks. There are a few specific blood tests that we do. And there's also considering whether or not they might need any hormone treatment to support, and how we could help them with early treatment, early surveillance with an ultrasound scan, and for the small minority, whether or not they might need some blood thinners through pregnancy.
Yes, so from gynecological side, as one of the perceptions women have is that they've got some abnormality, and when we talk about abnormality, they think that their womb may not be capable of hosting a pregnancy, or there is something very wrong with them. And that something wrong is very vague, because a lot of people, even though they may have idea of how the female reproductive system works, but this feeling of something wrong, we talk about the problems with the womb itself, if they've got any lesions which could be a fibroid, or if they've got uteruses that are slightly differently shaped and all that. And we do the scans, and most of the times the problem is not there. And therefore, as we know that the most important and relevant investigations, they are the blood investigations. So we reassure them that there is nothing wrong with their reproductive organs, but then their frustration is there must be something wrong. So that blood problem, you tell our viewers what are the blood problems and what is their relevance, and if we find a problem, is it treatable or is it not treatable at all. So throw some light on the blood investigations that you perform for them.
Well, some of it's just really basic, because sometimes women that have been through these situations haven't really paid attention to their own health. They've been thinking about a baby and how the baby's going to be, but maybe not how they are. So quite a lot of them will be iron deficient. Many of them might have other basic abnormalities in their blood count, their biochemistry, and so we would check that out. For some women, they might have an underactive thyroid gland. That's this gland in the neck that helps with our metabolism. And we know that an underactive thyroid gland can contribute to the risk of miscarriage. And they may benefit in that circumstance from some thyroid hormone replacement. So that's one of the things that we check alongside. There are some vitamin and mineral tests that we consider. And then there are sticky blood tests. Now, in the past, it was believed that genetic sticky blood tendencies or thrombophilia would contribute to the risk of miscarriage. And for many years, that was out there, and it still is, and people still think that that is the case. But actually, the evidence that we have now is that that is not relevant. A genetic clotting tendency is not relevant unless it's very severe and associated with a past history of thrombosis. And of course, we treat those women differently. But for what is significant is women that have something called antiphospholipid syndrome. Now, antiphospholipid syndrome is difficult, isn't it? It's got quite a strange name. And the reason it's got that name is because phospholipid is a substance that makes up the surfaces of cells. And one of the things that can happen in the course of normal everyday life is that we produce antibodies in response to infection and other challenges. But as well as producing good antibodies, we can also produce antibodies which aren't very helpful or can even be actively harmful. And these are called autoantibodies. And people may well have heard of a number of diseases which can be associated with autoantibodies. And there's a lot of allergic type conditions as well that people will have heard of. What happens in this situation, antiphospholipid syndrome, is that you get antibodies which have the end effect of activating your clotting system. And that can increase the risk of blood clots, but it can also contribute to an increased risk of recurrent miscarriage. So, for women that have suffered recurrent miscarriage and who have positive tests for antiphospholipid syndrome, we'd like to confirm it because you can have a one-off positive test and that's not relevant. But once you've had those tests confirmed 12 weeks later, then a woman may well benefit from having blood thinning treatment in pregnancy. And that has been shown in studies to be associated with a much better outcome from pregnancy.
Yeah, it's so difficult when women come to our clinic. They give a reference to one of their friends who went to a private clinic and they were offered so many treatments. For example, they are given steroids, they are given aspirin, they are given immunoglobulins and all that, so much stuff. And they think that just because our clinic is NHS clinic, we are depriving them of some very important treatment which will make a difference to the outcome. So what would you say about the treatments that are offered in the private sector and we in our NHS clinic are not offering them?
So we are incredibly lucky in the NHS that where treatments have an evidence base behind them, we are able to give those treatments. It is difficult giving treatments which don't have evidence because they can cause harm. And of course, what we're all about in the NHS is not doing harm. So what we do in our clinic is we listen to couples, try to understand their experiences, try and find out if there's anything that we can treat that has a good evidence base behind it. But we don't offer treatments that we know might cause harm and don't have an evidence base, because that in itself can cause problems down the line. There is no such thing as a drug that doesn't have a side effect.
Absolutely. And this is one thing which is very important for people to understand, that they think that any treatment should be given to them, whether or not it is supported with evidence. But actually, the recognition that some treatments can, in fact, cause harm. For example, aspirin is something that historically, any woman who had repeated miscarriages, they were started on aspirin from the beginning of the pregnancy, with or without investigation. So what would you tell our viewers why it is important not to have aspirin unless they have been advised to take that?
Yes. So, I mean, in the past, a lot of women were given aspirin, and in fact, a lot of doctors were just taking aspirin for themselves. It was seen as a sort of panacea for all ills, to prevent blood clots, to prevent miscarriage, to prevent all sorts of things. And I don't want to totally dismiss it. It is a very useful, powerful drug in the right setting. But what we shouldn't think of aspirin is as a sort of smarty supplement that can just be taken ad hoc, because there is some evidence that it may even contribute to worse outcomes if not used in the right setting. And we know, for example, as well, that aspirin can cause stomach ulcers. And indigestion, of course, is a common symptom in early pregnancy. So that can, that has potential to cause real harm.
Yeah, and so when a woman is diagnosed with a blood or hematological disorder and they require treatment, how easy it is for them to be offered treatment? Do you give them the prescription or do you advise their GPs to give the prescription? How does it work, and how easy it is to educate women on how to inject themselves if they are given injections?
So what we always try and do is create a shared plan which everybody has visibility of. So the GP is aware, but most importantly, the couple are very clear on what precisely needs to happen when and how they can reach out if they need help. So they've got our phone numbers, they've got our email numbers, we've got the specialist nurses, we've got the psychologist, we've got myself that can offer help as and when needed. Some of these medicines can be simply given by repeat prescription from the GP, and that's often very convenient because it's close to home. But sometimes it can be a bit of a delay getting treatment started, so we can always get them started with some medication along the way. And then if we do prescribe medicine, we are, of course, responsible for the outcome of those medicines. So we would then keep an eye on on the woman as she goes through her pregnancy. But we would always try and do that in a sort of minimally invasive way, because we want them to have a really joyful experience of pregnancy, which isn't interrupted by lots of medical appointments. So we try and just keep in touch, perhaps by phone, intermittently, or as and when they would like us to do any necessary checks, and also to provide them the reassurance as pregnancy progresses, address any questions they might have, and get ready for the birth of their child.
And you would have seen a lot, some women, they are needle phobics, and when it comes to injections, they find it very hard. So what advice do you give to them? How do you support them in that situation? Because this is one of the things that I'm sure you come across every now and then.
Yeah, and it's very understandable, isn't it? I mean, who wants to stick needles in themselves? It's not something, it would be very unnatural if you thought of that as a fun and easy thing to do. But what I would say is that I have never yet come across a woman who cannot cope with these injections in pregnancy. Sometimes their partner will help them with the injections, or another family member, and it's amazing how they do come to terms with doing these injections. We get them to inject in different places so they don't get too sore in one place, and we give them little tips and hints to make it a bit easier. But what's really great is that quite often when they have mastered it, when they've been really frightened of doing it in the first place, they feel incredibly proud of themselves and incredibly proud of how they've done this positive thing to help bring their baby into the world.
And I think you would agree that this is something that moms, they can do anything to have a child. And therefore, I think even if they're needle phobic, the phobia actually goes away when it comes to trying to have a successful conception. So I mean, we feel so privileged that our trust supported our joint clinic, where we invite these patients and we encourage the couples to come as well, so that all their fears and worries could be addressed, and we can give them the reassurance, because we know that those women or couples who do not require any treatment, just the reassurance that we are just a phone call away makes a huge difference, because getting access to the health facilities, GPs, they are so busy, so they may not get appointments. So that in fact makes a huge difference. And you mentioned about the psychologist as a part of our team. Would you kindly tell us about the role of the psychologist, and does it actually make a difference?
Well, I think it's made a huge difference. So if you think about psychology, what psychology is it's not so much counselling as like an emotional form of exercise therapy. It helps you to look at the traumas that you've experienced and put them in a new light, and develop some coping strategies. And there may be specific techniques. For example, our psychologists use something called eye movement desensitization. So there's some practical techniques which can help deal with that emotional trauma, because some women in particular do find themselves in a really difficult situation emotionally. And quite often that has come because of the trauma they've suffered on a background of difficulties in earlier life. And that can mean that even if they have a successful pregnancy, the whole experience is very miserable for them. And of course, we all know that it's much better for the baby if mum is happy through pregnancy. And so that's what we want to do. We want to set people out on the right path. We want to challenge any misconceptions they might have, like, this is my fault, I'm being punished for this because of something I did at some point in my life. Absolute nonsense. I'm somehow inadequate or inferior because of what has happened. Absolute nonsense. It's a really hard thing to go through. You're worthy of compassion and love and support. And thankfully, most couples will then go on and have a very successful pregnancy.
Yeah, we have seen so many success stories, and it is very rewarding for us when we see couples going through this journey and having a successful and a happy outcome. It's just unbelievable, because it's very rewarding for us. Now, With regards to the general health advice, what do you tell the patients in terms of general advice that they should follow? Because especially in ethnic minorities, there are some cultures where there is a lot of family pressure as well, where mother-in-laws or family members, they are just expecting that as soon as the couples, they get married, they should start producing, and when it's not happening, they just put in their head that there is something majorly wrong. So how do you counteract that kind of a feeling in such couples? What do you do to help them?
Yeah. So, they are not to blame. And the general health issues are about helping them go through a successful pregnancy. We don't identify general health issues which have caused the miscarriage. We try to just help them get to the best place so that pregnancy will be an enjoyable experience. And many of those things are just very simple day-to-day things. Get enough sleep. 8 hours sleep is the ideal. Drink water regularly and eat a broad and healthy diet. There's a bit of I think it can be difficult for vegetarians because the easiest source of iron for human beings is meat. And so for vegetarians, it can be a little hard to maintain iron stores, and around 40% of women of childbearing years are iron deficient. So if you are a vegetarian, you can be perfectly healthy and have plenty of iron, but you do need to think carefully about that. People tend to assume that like spinach is good for iron, but in fact you kind of have to have a kilo of spinach for the equivalent of one burger. So that's quite a lot of spinach. So spinach is great, wonderful. All fresh green vegetables are really good, but to get some good iron, if you're a vegetarian, you need to be thinking about lentils, pulses, nuts, dried fruit, and the like to make sure that you've got the right balance. So a good, healthy diet, regular exercise to maintain physical and emotional health.
Yeah, I've seen you talking about adding fruits and vegetables, because a lot of people, they are not very fond of fruits and vegetables, and it's just a simple, basic dietary adjustments, getting rid of all the rubbish food which is like takeaways, and as you mentioned, good sleep, exercise, eating healthy, and most importantly thinking positive, because we have developed our slogan that you have to eat healthy, breathe healthy, and think healthy, because these are the basic things which we have seen in numerous cases. In the absence of any problem, we see that women have had successful outcome just by this encouragement, TLC, support, and access to our system. So one thing that we see often, that women, if they are anemic and they are trying to build up their iron stores, they take 3 or 4 times a day iron tablets. What would you say to our viewers? Is it good or bad to have so much iron?
Well, you see, that is very interesting because the British National Formulary does advise iron 3 times a day. But in fact, the latest evidence is that if you take too much iron, you absorb less. So our body responds to too much iron by reducing the mechanisms that allow you to absorb iron. So in fact, the best iron, if you have to take a supplement, a stronger supplement. So a standard daily multivitamin or a standard over-the-counter iron supplement, you can take once a day with preferably fruit juice or squash, because anything containing vitamin C increases absorption. But if you take prescribed iron, so that's a strong iron tablet like ferrous sulfate 200 milligram once daily, or ferrous fumarate 210 milligrams once daily, actually you're better off taking one tablet on alternate days. With fruit juice or squash, and preferably not with milk, because iron absorption is impeded by milk. So milk or dairy products are good for you in general, but not when you're trying to absorb the iron at that point in time.
Yeah, that is fantastic. So now, I think we have covered most of the things that couples want to hear, and the message that we have understood is for women especially not to feel guilty or not to take the blame, or if they have not been successful, because by just basic adjustments in their life, thinking positive, there is no reason why they can't have children. And sometimes the women, they think that going for IVF may be beneficial. What would you say to them if they think, and they are not in that age group where we worry about the quality of their eggs? Is IVF in any ways beneficial for them, or it's just a waste of time as well as the money?
So I'm no expert on IVF, and I'm sure there are specific circumstances that may well be helpful in and is helpful in. But in the context of recurrent miscarriage, it's not particularly helpful unless there are very specific familial problems, which are incredibly rare. So they're better off thinking about the normal approach to pregnancy. And also, you're right, Amara. It's about thinking beyond. So, and that is really hard when you've had to face a series of losses. What can be really hard is to think beyond, because when you try and think beyond about having that healthy child, that can feel difficult. But that's the place you need to get to. You need to get to a place of thinking, yes, this can happen for me. We haven't found anything that can get in the way, and most women, most couples can end up with a successful pregnancy, and why shouldn't that be me?
Absolutely. So thank you very much, Tamara. It was very useful. But before you go, I know you are very busy today. Would you kindly just give a general advice to the couples who have suffered from recurrent pregnancy losses and there is nothing wrong with them?
Yeah. So I'd say believe in that. Believe in your relationship, believe in each other. Don't let other people detract or give you any magical answers or magical criticism. Both of those are wrong. Believe in yourself, believe in each other, and look after yourself. And then when you are pregnant, come back and show us your baby, because we're always delighted to see that.
Absolutely. It's so rewarding. Thank you ever so much, Tamara, once again for your time. And we look forward to having you again with more wisdom on a different topic. Thank you.
No
Goodbye
problem.
for now.
Thanks, Amara.
So viewers, you heard about how the couples who go through recurrent pregnancy losses are managed in these dedicated clinics. The main message is, if there is nothing wrong, believe in yourself. It may just be a time when you have been unlucky, but in the absence of any problems, there is no reason why you can't be parents, and therefore just believe and stay positive. So I hope you benefited from this information. So goodbye for now. I'll be back with another show next week. Goodbye.